And I'm in a position where I'm showing my age because I don't have progressives. And so I can't see any of you really when I take my glasses off, but I need my glasses off in order to read my own notes. So I think that's probably how it's going to go here as I go through the slides. So to start with, what kind of motivated this project, and we're grateful to CRISM Atlantic for the funding. This was the Knowledge Mobilization project that we did for 2021. And what motivated it was that there were people in PEI, people with living and lived experience in PEI who had hosted a call to action in 2020, voicing concerns regarding addiction services access and availability of services. And the call to action highlighted a disconnect between people with lived and living experience and service provision in PEI, and posed an opportunity for increased collaboration and understanding and knowledge sharing, and a need to re-examine the services available in PEI and barriers to service. So what our knowledge mobilization project included was we brought together 2 people with living experience, one clinician who self-identified as an individual who had lived experience, and 2 researchers to share knowledge on barriers to accessing services in PEI and virtual solutions to some of those barriers. Our objectives were to enhance collaboration among our project team, as well as CRISM Atlantic Quebec, CRISM Quebec Atlantic Network, and collectively share resultant information and knowledge gained through a virtual knowledge mobilization activity. And as well, provide mental health and addictions leadership with new knowledge to inform services in PEI. I'm realizing that I need my hands to keep going here. So CRISM funding enabled us to appropriately pay our partners with lived experience. And so we used the funding for that, which we were happy to have, and acknowledging their time and contribution to the project. We met as a group 5 or 6 times over a period of a couple of months, and our partners at the time, our lived experience partners at the time, gave feedback that they felt appreciated, they felt valued for their perspectives and as equal partners. And they appreciated the funding. And substance use treatment needs and barriers identified through lived experience. So this project provided a valuable opportunity to engage with our partners with lived experience in a collaborative and informative way. It provided them with an avenue to share their experiences and their knowledge and that of their peers. So our 2 representatives shared stories of their own experiences, the experiences of peers that had accessed services, and they highlighted some challenges, for example, inconsistency around inpatient triage processes for withdrawal management, communication and collaboration lacking between services and departments, system navigation issues, stigma from general public and also from some staff, needs for collaboration between people with lived and living experience and government services, or people who deliver and organize the services, was another need that was mentioned. My mouth is very dry. I'm nervous. Okay, so PEI focused research on barriers to treatment. So we also looked into what research was available in PEI on barriers to treatment, and we found 2 studies. There was a study by the Department of Health and Wellness in 2018. It was the take-home naloxone program survey, and they had 18 participants and found that 72% reported feeling stigmatized as an opioid user. Thank you. And then Injecting on the Island was a study from 2014 where they interviewed 8 individuals who self-identified as injection drug users in PEI and found that there were reported incidents of stigma, including perceived stigma from healthcare professionals. as well. In 2020, myself and Dr. Amanda Hudson, who is also a member of CRISM and unable to be here today, but we conducted a mixed method client survey of opioid replacement therapy for clients in PEI. It was called opioid replacement therapy at the time. Now it's referred to as opioid agonist therapy. It was a mixed methods study with 119 people across the province, and we looked at reasons, program retention difficulties, which you can see some of them listed here. Reasons for retention difficulties indicated mostly transportation, stigma, treatment not considering other health or living conditions, determinants of health and so on, as well as satisfaction and level of their thoughts around adding peer supports and telehealth. And there was a strong endorsement towards peer support and telehealth, and peer support in particular. There were 110 comments, which were analyzed thematically, and I don't have a slide on that, but just trying to keep it within reason here. But the biggest theme was around interpersonal and ability to relate with peers and trust and respect. We talked about virtual solutions, and those being solutions that include services via telehealth or phone calls or apps. And the goal of those services to improve accessibility, reduce barriers related to transportation issues, scheduling or geographical barriers with a lot of folks living in rural locations in PEI, to address concerns about privacy and stigma and increase program retention. And some virtual solutions we discussed in our group around what was available in PEI, including Bridge the Gap, which informs different where people can get different services and what services are available. We also talked about remaining challenges like stigma and access. And to address those challenges, we looked at education. This is kind of what came out of our discussions within our committee. The need for education, particularly for staff within mental health and addictions, ensuring that they have education on trauma-informed care, recovery-orientated care, person-centered, strength-based, and using person-first language, as well as a communications plan to share a way of sharing information and engaging and consulting with people with lived and living experience in a meaningful and respectful and sustainable way. As well, to offer peer supports as part of service delivery in the province, and to expand outpatient services. Our committee held a knowledge mobilization event in June of 2021. And what we did was, it included research presentation. I can't see what that says. I think it says 5 minutes. That's the benefit, maybe. Research presentation, substance use. We looked at substance use treatment needs and barriers identified through lived experience. PEI-focused research on barriers to treatment, stigma as a barrier to seeking help, and virtual solutions that are available in PEI, and facilitated a discussion around remaining challenges, lessons learned, and next steps. And our project outcomes, I might be lost here now. Yeah, and I wanted to say with that knowledge mobilization event, we had our partners with lived and living experience shared a lot, and that, I think I already mentioned that before I talked about the event, but that was a real key piece, and it was very powerful, really, to hear people's stories of their own experiences and that of their peers, and it was really the highlight of our event. As well as our lived experience person with our clinical person with lived experience as well. And so our project outcomes, we enhanced collaboration, enhanced understanding of barriers to service services in PEI, increased the knowledge of available services, and identified steps to further reduce barriers and maximize effectiveness of virtual innovations. And recognizing that virtual innovations or solutions are a piece of the puzzle, but they don't necessarily address stigma or people, who don't have access to internet in rural locations or whatever. Lessons learned. There's many more than these, but these were kind of a couple of the key ones. Ongoing efforts are needed to reduce stigma and improve access to treatment services, and recognizing and including people with lived and living experience is vital, and their experiential knowledge is invaluable, and we need to really respect that. So progress since the event, we now have increased participation of people with lived and living experience within PEI mental health and addictions on various committees. We also have folks as consultants, for example, providing input on development of the client and partner in care engagement surveys. We have a patient and family partners advisory committee now, and they're in partnership with Mental Health and Addictions Patient Navigator, and we've implemented a checklist for engaging people with lived and living experience in mental health and addictions staff training. So when we do training for staff, having people with lived and living experience who are willing to come and speak at some of that training. Where else am I? Peer support. We are adding a peer support coordinator position within mental health and addictions. Knowledge translation strategy is in development, and we have implemented open access counseling where people can come without an appointment and see a counselor. And I think that concludes my presentation. Thank you. Now I can see everybody.
Thank you, Nicole.
Thank you.
I should have mentioned, this is this work comes from a knowledge mobilization funding from CRISM, from the CRISM Quebec node. And what's really important is this is before the CRISM Atlantic had formed. Mm-hmm. And yet it speaks to one of the priority areas that we had identified in terms of telehealth and the need to sort of speak to that as the unique aspects of being a very rural, remote, and underserved population in Atlantic Canada in general. So it's quite nice that it sort of dovetails into the work that's being done. So sorry, I'm talking. Do we have any questions from the audience that I can run? Okay. Because you can, we can come speak to you at the break and have a question. And thank you. You did great.
Thank you very much.